Hi everyone, this is Dr. Chitra, your mentor at StudyMedic and StudyEFOG. And today in this video, we are going to see important points in urogynecology. So before we begin the study of urogynecology, we have to know a few definitions. So overactive bladder, detrusor overactivity, urodynamic stress incontinence, and pelvic organ prolapse. These are the terms that you are going to be encountering very frequently. What does overactive bladder means? So this is a symptom-based diagnosis, and it is defined as urgency or urgent continence. Sorry. It is defined as urgent continence. It could be wet or dry overactive bladder, and it presents with frequency and nocturia in the absence of any urinary tract infection or no underlying bladder pathology. Detrusor overactivity, on the other hand, it is characterized by involuntary detrusor contractions during the filling phase, and it could be spontaneous or provoked. So this is basically a urodynamic diagnosis. Urodynamic stress incontinence, it means that there is involuntary leakage of urine with increased abdominal pressure, and there is no detrusor contraction. And pelvic organ prolapse means there is falling, slipping, or downward displacement of the uterus and or the vaginal compartments and their neighboring organs such as the bladder, rectum, or bowel. Okay. Now first, whenever you are studying urogynecology, you should be able to interpret the urodynamic graphs. So we will first see how to interpret the graphs, and then we will see management of incontinence. Now understand that urodynamics, it is an invasive procedure, not routinely done. There are a few indications. So it is normally done in any woman for whom you are contemplating a surgery. Prior to surgery, you will do urodynamic studies. It is always also done whenever the type of urinary incontinence is not clear. Then whenever any woman presents with symptoms of voiding dysfunction, or a woman has anterior or apical prolapse. And also whenever there is history of previous surgery for stress urinary incontinence and the woman comes back to you again with some urinary symptoms. So normally these are in the indications for which you will do urodynamic studies. Now urodynamic studies, remember, it will test the function of bladder and urethra. Now there are different types of urodynamic function tests that can be done. So you have uroflowmetry, cystometry, video urodynamics, then you have urethral pressure profile and ambulatory urodynamics. Out of this, uroflowmetry and cystometry are the ones that are routinely done. The others are done for very specialized investigations. Now, if you see this graph, this is the voiding graph, okay? And this is a bell-shaped graph. Can you see? So this graph is true whenever the volume of urine is more than 200 ml. And here at this time, this graph is plotted. On the x-axis, you have time. On the y-axis, this is the flow rate. So Qmax, that is the maximum flow rate, it should be more than 15 ml per second. So this is the bell-shaped graph that you get for voiding. Now, when will you get some abnormal graphs? So if you see the graphs here, in this Qmax is very much reduced. It is only 7 ml per second. So this you can get when the detrusor is not contracting properly or there is some obstruction. So, but mostly if it is obstruction, there will be more detrusor contractions. So this is typical of hypocontractile bladder. And in this graph, you can see that the flow is intermittent. That means you are getting flow, then there is stoppage, then again the flow begins. So this is typical of obstruction. Okay, these are the two types of graphs that you find which are abnormal. Now let us come to cystometry. So cystometry means you are testing the bladder when the bladder is getting filled. In this, there are three catheters that are there. One catheter is in the rectum that measures the abdominal pressure. Then there are two catheters placed in the bladder. One is for filling the bladder and the other one is for measuring the bladder pressure. So you will be measuring three pressures. One is the detrusor pressure, second is the vesical pressure, and third is abdominal pressure. Now understand here, vesical pressure is the total of detrusor and abdominal pressure. Okay. So whenever you are doing this cystometry, This is useful basically to know whether there is detrusor overactivity, there is urinary stress incontinence, and also it will record the different bladder sensations and different bladder volumes. So the normal capacity of the bladder is around 400 to 600 ml. The first urge to void should be at 240 ml and the flow rate should be 15 ml per second. Now from this three pressures that you get, to calculate the detrusor pressure, you will subtract abdominal pressure from vesical pressure. Okay. You can get two types of graphs. So let us first concentrate on this graph. Remember the line that is here at the bottom. This is the detrusor pressure. This is abdominal pressure and this is vesical pressure. So normally when the bladder is being filled, you should not be getting any contractions in the detrusor. The detrusor is supposed to be quiet at that time. In this graph, what you are seeing is that there is an increase in the abdominal pressure. Because an increase in the abdominal pressure, the vesical pressure is rising. Okay, but the detrusor pressure is not rising. And at the same time, what you can see here that there is a leakage whenever abdominal pressure and vesical pressure is rising. So this is typically seen whenever there is urodynamic stress incontinence. So in urodynamic stress incontinence, remember, detrusor pressure is not rising. Only there is a rise in abdominal pressure, there is a rise in the vesical pressure, and at the same time, you are getting a leak. So this is urodynamic stress incontinence. In this graph, what is happening here? You can see there is an increase in the detrusor pressure, or this is called as detrusor contractions. Abdominal pressure, the line is straight, and because detrusor pressure is rising, there is also corresponding increase in the vesical pressure. Now remember, in the filling phase, the detrusor muscle is not supposed to contract. So whenever there are contractions seen in the detrusor pressure, these could be either spontaneous or they could be provoked by running a tap. So whenever you get contractions in the detrusor in the filling phase, it is very typical of detrusor overactivity. Now, whenever you see a leak at the height of this detrusor contraction, this is urge incontinence. Okay, so the difference is whenever no rise in detrusor pressure, but there is a leak, it is urodynamic stress incontinence. Whenever the detrusor pressure is rising and at the height of the detrusor pressure, you are getting a leak. This is urgency incontinence. Okay. Now let us come to management of urinary incontinence. So before, the first important thing is history taking and a physical exam to identify the type of incontinence. And whenever you are contemplating any surgery for stress urinary incontinence, it is always better to talk to the woman about what is the benefit of non-surgical treatment and what is the medical treatment, both for stress urinary incontinence and well as overactive bladder. You have to identify what are the predisposing and precipitating factors. You will assess pelvic floor, especially in cases with stress urinary incontinence. And the most important thing is always rule out any urinary infection. You can also assess the residual urine, and for this a scan is preferred. And whenever you see that the post-residual volume is more than 100 ml, it is considered to be abnormal. You also find out how much these symptoms are affecting the quality of life. A bladder diary preferred for 3 days, in which you will have some days in which the woman is working and some days in which she is at home. So you get to know her overall pattern of symptoms. And you also should be able to understand that if there are some factors or some symptoms which are troublesome, you have to refer her to the specialist. Like supposing she complains that she is having hematuria, or there is pelvic organ prolapse, or she has already undergone some surgery for incontinence before, or there is a palpable abdominal or a pelvic mass. So these are the symptoms for which you will refer her to the specialist. Now let's see what are the modalities available for treatment of urinary incontinence. So the first modality is lifestyle intervention. In the history, you have to find out about the amount of caffeine that she is taking, and anybody with overactive bladder or stress urinary incontinence, you have to tell them to stop caffeine intake or reduce it. She has to be drinking adequate fluid, so at least 1.5 to 2 liters of plain water. Whenever BMI is more than 30, advise weight loss. The second is physical therapies. So in this, you have pelvic floor muscle training. In this, a trial is given for 3 months for anybody who has stress urinary incontinence or mixed type of incontinence. So here she should be performing 8 contractions 3 times a day. And if this is beneficial, then she can continue. The other is electrical stimulation. So this is not routinely done in overactive bladder. It can be done for those who have stress urinary incontinence. And it can be considered if the woman, she cannot actively contract the muscles. Then you have behavioral therapies. So this is basically done for urgency or mixed urinary incontinence. In this, bladder training is advised for a period of 6 weeks. If it is not satisfactory, that means the symptoms are not well controlled, then you can add some drugs, especially like if frequency is a major concern, then you will add some medicines to this behavioral therapy. Next is neurostimulation. This you will not routinely offer unless the woman has been reviewed by the local MDT. Neurostimulation is offered for overactive bladder. In this, you have transcutaneous sacral nerve stimulation, which is not routinely offered nowadays. And then you have percutaneous tibial nerve stimulation. And this is offered especially if the woman doesn't opt for botulinum toxin. Now, absorbent containment products or urinals or toileting aids, these are offered only as a coping strategy. Okay, you are not routinely offered. Then you have invasive procedures. So for overactive bladder, you have botulinum toxin, you have PTNS, there is cystoplasty and urinary diversion. For stress urinary continence, the surgeries that can be offered are colposuspension, autologous rectus facial sling, or intramural bulking agents. Let us see management of urge urinary incontinence. So bladder training. Now, what is the aim? The aim for this is that the woman should be able to regain control of her bladder, and she should go to the toilet to pass urine only when she wants to, rather than whenever she gets the urge to go. So for this, you have to tell the woman that she should be practicing some distraction techniques, like she can count from 50 to 100, she can recite alphabets or any reciting or any distraction technique she can perform. And gradually, she has to increase the interval by which she goes to void urine. So initially, she can avoid going to the going to the bathroom every half an hour. When she is satisfied with half an hour, she can increase the duration to 1 hour, then 2 hours. So gradually she has to increase the duration or decrease the frequency so that she is avoiding 6 to 8 times in a day. The other is drug therapy. In this, basically, we have antimuscarinics, but they have a lot of side effects like dry mouth, constipation, blurred vision, somnolence, and that is why they are not readily accepted by the patients. Remember one thing with drug therapy, you have to use it with caution, especially old, frail women. And here for these women, you can opt for transdermal preparations rather than oral. Another drug that can be used is desmopressin, especially for women those who have nocturia. It is very helpful, but you have to be cautious about using this drug. You have to monitor electrolytes at 1 week, 4 weeks, and 6 months. And you have to be very careful or use it with caution in women, those who are elderly or those who have cardiac disease, they have previous hyponatremia, and those who are on diuretics. The third drug that we have is mirabegron. Now, this is a potent and selective beta-3 adrenoceptor agonist. But here also, you have to use it in caution with women, those who have hypertension. Now coming to botulinum toxin. So the toxin that is used is type A. This is done, or this is offered to the woman only after the local MDT review has been done. The initial dose that is to be used is 100 units. Before offering botulinum toxin, you have to counsel the woman that symptom relief is good, but sometimes it can last for less than 6 months. And if that happens, then you will have to increase the dose to 200 units. The relief of symptoms, it could either be complete. For some women, it could be partial relief of symptoms. Another important thing that you have to tell that sometimes these women can need clean intermittent self catheterization. And this comes with its risks. So you have to counsel them if they are able to do self-intermittent catheterization, only then offer botulinum toxin, or they should be able to accept indwelling catheter for some period of time. And after this botulinum toxin has been offered, then you will either offer her a face-to-face or a telephonic review within 12 weeks of treatment. The other mode of treatment is percutaneous sacral nerve stimulation. So this is offered whenever there is no response. This is not sacral nerve, it is percutaneous tibial nerve stimulation, sorry. Whenever there is no response to previous modalities, this is tibial. There is a risk of failure. It is a long-term commitment, and there could be a need for surgical revision. And there could be adverse effects, like there could be transdermal, the implant can migrate. So this is an invasive procedure, always done after the MDT review has been done. The other surgeries that can be offered are augmentation cystoplasty. Now, this can lead to bowel disturbance. You can have metabolic acidosis. There is mucus production because you are implanting a part of the bowel into the bladder. So there could be mucus production. This can get retained into the bladder. And you can have urinary tract infection and also urinary retention, a very low risk also of adenocarcinoma. This needs lifelong follow-up. So the woman has to be committed for lifelong follow-up. Urinary diversion, this is one of the last options. And for this also, lifelong follow-up is needed. Now coming to management of stress incontinence. So the first thing that is usually offered is conservative. So pelvic floor muscle training for 3 months, 8 contractions, 3 times a day. The other is weight loss, especially if BMI more than 30. Surgeries that can be offered are, the first option is colposuspension. It can be open or laparoscopic depending on the facilities that are available. Then you have autologous rectus facial sling or retropubic mid-urethral mesh sling. Intramural bulking agents can be offered. Remember, these are permanent. Repeat injections may be needed, and there is limited evidence. So they are less effective than the other surgical procedures. The last is artificial sphincters, and these are not offered unless other surgical procedures have failed. Coming to mid-urethral slings, the important points that you have to remember here, these are permanent implants and complete removal might not be possible. Whenever you are offering this, remember to use a device manufactured from type 1 microporous polypropylene mesh. Do not use the top-down approach. Use down-up approach, and do not use single incision suburethral short mesh sling insertion. Also, transobturator approaches are not offered unless there is a special circumstance, like the woman has undergone previous pelvic procedures. Only in this, then, transobturator approach is offered. Let us see a few questions that you might be asked in the exam. So you have this 60-year-old woman who presents to the gynec outpatient clinic with 6 months history of urinary urgency, daytime frequency every hour, nighttime frequency of 3 to 4 times. There has no urge or stress incontinence. And she has had 3 times urinary tract infections which have been treated. She is menopausal, she's postmenopausal, not on any HRT, and she has had 2 vaginal deliveries in the past. General examination is unremarkable. Um, she in the local exam, she has atrophic external genitalia and grade 1 cystocele and grade 1 rectocele. No uterine descent. Cervix is healthy, no adnexal mass. Urine analysis shows RBCs and leukocytes. So, what will be the next step in her management? Okay. Remember, you have a postmenopausal woman, everything else is normal. Why does she have RBCs? And she has recurrent urinary tract infections. Whenever you have something which is abnormal, urine microbiology is not going to offer you anything because her urinary tract infections have already been treated. The first thing that you will offer her is a cystoscopy to see whether there is anything in the bladder. It could be a bladder malignancy. So, RBCs, hematuria, for all of this, always first do a cystoscopy if the urine routine has already been done. If not done, first always choose the option that is least invasive. So here, urine routine has already been done. It is showing RBC. So that is why cystoscopy is the first option to be chosen. Now next, you have this urodynamic graph in which the woman is complaining of urgency more than 10 times during the day and 2 to 3 times at night. She has no urge or stress, urinary incontinence. So, incontinence has already been ruled out. What are you going to see here? So, here, remember, whenever you have the graphs, the lowest one will always be detrusor. Then, this will be abdominal pressure. And the last one, this will be the this is detrusor, this is vesical, and this is abdominal. Now, what you are seeing here in the red line, you have an increase in the detrusor pressure. Because detrusor pressure is increasing, also the vesical pressure is increasing, but abdominal pressure is not rising. Now, in the filling phase, whenever there are detrusor contractions seen, the only diagnosis that you can have is detrusor overactivity. Since there is no leak shown here, it is not incontinence. Okay. Another question would be like, you have this 32-year-old woman with 1 child, referred by her GP because she has a history of urinary leakage whenever she is exercising. No other symptoms. Frequency 4 to 6 times during the day, once at night. No prolapse, no bowel symptoms. She had a delivery 2 months ago. She's breastfeeding in the baby and she's planning for another child in 2 years' time. Her BMI is 22. General abdominal examination is unremarkable. Vaginal exam, no evidence of prolapse. Cervix is healthy, uterus is anteverted. There is no demonstrable stress urinary incontinence. Urinary analysis was normal. So what is the most appropriate next step? Remember, for this woman, she has not completed her family. She is planning another delivery or she's planning another pregnancy very soon. So for these type of women, you will not offer her any type of surgery. Okay. Urodynamics not needed to be done because you are not planning any type of surgery. What you can offer her is bladder training because she has frequency, but it is 4 to 6 times per day. It is not really too much of frequency. The most important symptom that she is having is urinary leakage. So I would prefer to offer her supervised pelvic floor exercises. Topical estrogen therapy, because she is not postmenopausal, there is no atrophic vaginitis, and duloxetine is not routinely offered for treatment of urinary incontinence. So here the correct answer is supervised pelvic floor exercises. Remember, women, those who are young or any woman presenting with urinary incontinence, the first option that you would offer them is conservative measures in the form of supervised pelvic floor exercises. And you would offer surgery only if a PFMT doesn't work or the woman has completed her family and the symptom of SUI is really very troublesome. You have a 50-year-old woman. She has undergone surgery for SUI. but she has come again with complaints of incontinence. So what is the next management plan for her? Already surgery has been done. So will you offer PFMT? Not really, would not really be very helpful. Urodynamics, yes, could be offered. Already surgery has been done. So no role of offering corpus suspension or sacrocolpopexy again. You will go in for urodynamics to see whether in addition to her stress incontinence, she also has symptoms of overactive bladder, okay, or detrusor overactivity. So stop the video here, pause the video and see what are the indications for doing urodynamic studies. Now you have a lady, she presents with urgency, frequency, as well as nocturia. She has both urge and stress incontinence. So what would be the most important management option for her? Remember this woman, she has both. She has urgency, frequency, nocturia, and well as incontinence. So for her, you will have to offer her both pelvic floor muscle training as well as bladder training. Okay, the first option that you would offer her, it should be the symptom that is more prominent. But here, since she has both symptoms, she has urge, stress incontinence, as well as symptoms of overactive bladder. So you will offer her both PFMT and bladder training. Okay. Now you have this 84-year-old woman. She presents with a vaginal bulge and she has urinary frequency and urgency. She describes episodes when she could not pass urine when she goes to the toilet because maybe of the cystocele. When she has undergone an exam, it revealed anterior vaginal wall prolapse, moderate uterine prolapse, and moderate posterior vaginal wall prolapse. So what would be the next appropriate step in her management? Admit vaginal plaquing and self-retaining catheter, insert a self-pessary, and book for pessary replacement as usual. Don't insert the pessary, give her local estrogen cream and book for another appointment in 2 weeks to reinsert the fumed ring pessary. Reinsertion of the ring pessary, surgical management of pelvic organ prolapse. She is 84 years old, so you will not offer her surgery. The obvious thing that you would do for her is you will insert a shelf pessary now, and remember that whenever you are inserting a shelf pessary, you will call her back again, okay, because the shelf pessary, it has to be removed and you have to replace. So booking for a pessary replacement as usual. Now this woman in the previous scenario, she got a shelf pessary inserted, and after 2 weeks, she has come back for a follow-up. And this time she complains of mild discomfort, there is some blood-stained vaginal discharge. And when you see her locally, she has vaginal ulcerations. So what will you do for her now? Pause the video, look at the options. Remember, she is having trauma. So whenever she is having trauma, you will not reinsert the pessary. You will remove the pessary. You will give her local estrogen cream for local application. And you will call her after 2 weeks to reinsert a new vaginal pessary. Remember, this vaginal ulcerations, it is a recognized complication of using vaginal pessaries for pelvic organ prolapse. Okay, so you will have to first treat the ulceration, okay, by using local estrogen creams. And after that, you will call her after a couple of weeks for a follow-up, ensure that the ulcers have healed, and then insert a new pessary. And if the ulcer is still present, then the pessary is not inserted. Now you have another woman, 30 years old. She presents with moderate uterine and moderate anterior and vaginal prolapse 6 weeks after her delivery. Now this was a traumatic delivery. She had undergone a forceps delivery and episiotomy was done. After that, she describes a bulge and pressure per vaginal, especially when she is doing some activities like she picks up her baby. She also has urinary frequency and urinary incontinence and urgency. Sorry, no incontinence, only frequency and urgency. She's sexually active and has no other medical problems. What is the most appropriate option for her? Pause the video here. Think, young woman, just undergone a delivery. So you can either put in a pessary, ring pessary, or a shelf pessary. She is sexually active, remember that. Or you can offer her some type of surgery. The correct option is insert a ring pessary. Okay, because she is young, not yet completed her family. So you will not offer her any type of surgery. A pessary. Now, out of the two pessaries, ring pessary and a shelf pessary, because she is sexually active. With the shelf pessary, it is it is something which occupies the vagina. So she cannot be sexually active. So shelf pessary is not offered. You will offer her a ring pessary. And because she is young, first always offer conservative management. If that fails, only then you can offer her some type of surgical procedure. And also at the same time, you can offer her pelvic floor muscle training. Next, let us come to pelvic organ prolapse. In this, you have to be knowing this POPQ system. Remember, in this, there are 6 points measured in the vagina with respect to the hymen. Points which are above the hymen, they are negative numbers. Points which are below are positive numbers. And all the measurements, except the total vaginal length, they are measured at maximum Valsalva. Now, how do you measure the genital hiatus? It is measured from middle of external urethral meatus to posterior midline of the hymen. Perineal body, it is measured from posterior margin of genital hiatus to middle of anal opening. And total vaginal length is the depth of vagina where point C or point C is reduced to normal position. Let us see what are these points first. Okay. So have a very careful look at this picture. First, we will see point AA. What is this point AA? This is on the anterior vaginal wall, 3 centimeters proximal to the hymen. It can be -3 to +3. Then you have point BA. This is the most distal position of the remaining upper anterior vaginal wall. This can also be -3 to plus total vaginal length. Then you have point C. So point C is the most distal edge of the cervix or vaginal cuff if the woman has undergone hysterectomy. Point D is on the posterior fornix. You will not have this point D if the woman has undergone hysterectomy. Then you have point AP. So point AP is on the posterior vaginal wall, 3 centimeters proximal to the hymen. Point BP is the most distal position of the remaining upper posterior vaginal wall. Point AP and point BP, they can be -3 to +3. Then this is the total vaginal length. This is the perineal body and the genital hiatus. So why do you measure all these points? Because you want to grade the prolapse. You want to stage the prolapse. To stage 0 is when all the points, they are in their normal position. That means there is no prolapse. Okay. Stage 1. So whenever the criteria for stage 0 are not met and the leading edge is less than -1 centimeter from the hymen. This is stage 1. Stage 2. Whenever the leading edge is below -1, but it is still less than or equal to +1 centimeter. Stage 3. Whenever the leading edge is more than 1 centimeter, but it is less than the total vaginal length, -2 centimeters. That means the whole vault has not prolapsed. And stage 4 is whenever the leading edge is more than or equal to total vaginal length -2 centimeter. That means the whole vault has everted. That is stage 4 prolapse. Okay. Pause the video here. Very carefully read all the points and you have to memorize the stages of prolapse. Now, based on this, let us see or let us try to identify the type of prolapse. So this is basically given in a grid where you have points AA, BA, point C. This is the genital hiatus. Then this is the perineal body, total vaginal length. These are the posterior points. Now, because this woman has undergone a hysterectomy, point D is not applicable. So here what you are seeing is that point AA is 0. That means it can be -3 to +3. Okay. So it is not -3, it is 0. BA is also 0. Point C is -6. That means this looks to be like a type of anterior vaginal wall prolapse. Why? Because point AP and BP, these are -3. That means they are in their normal position. You are having only anterior vaginal wall prolapse. Let us have a look at the second grid. In this grid, point AA and BA are -3. C is -8. Total vaginal length is 8. That means there is no anterior vaginal wall prolapse. Whereas if you see point AP and BP, they are at 0. That means this is a posterior vaginal wall prolapse. Okay. In the third grid, point AA is +3. Definitely it has prolapsed. It has come out from the hymen. BA is +8. C is also +8. That means that there is anterior vaginal wall prolapse. AP, that means the posterior wall, it is +3. That means that has also prolapsed. BP is +8. So this is a total vault prolapse, because if you see point BP is +8, point C is 8, and total vaginal length is 8. So this is a total vault prolapse. A little bit about post-hysterectomy vault prolapse. So you have this 45 years old woman who presents with a vaginal bulge and pressure. She has post-hysterectomy vault prolapse following vaginal hysterectomy and pelvic floor repair for pelvic organ prolapse 2 years ago. She is generally fit and well. No other operations she has undergone. She is sexually active and she does not wish to have a vaginal pessary inserted. So which is the most appropriate management option for her? She is sexually active, okay? Colpocolysis would not be really good for her because that would completely obliterate the vagina. You can offer her a mesh pelvic repair. You can offer pelvic floor repair. Sacrospinous fixation is an option, but remember she is sexually active. And this would lead to shortening of the vagina. Then you can offer her a sacrocolpopexy, or you can offer uterosacral ligament fixation. Out of this uterosacral ligament fixation, not very routinely done. The option that is most appropriate here is sacrocolpopexy, either open or laparoscopy. Why? Because she's a young woman, 45 years old, and this sacrocolpopexy, it is the gold standard surgical procedure for repair of post-hysterectomy wall prolapse. This woman, she has no other risk factors, no medical problems, no previous abdominal operations. Okay, so that is why you will offer her a sacrocolpopexy. And remember, it maintains the length of the vaginal vault. So that is why it is not contraindicated for her, whereas colpocolysis or sacrospinous fixation of the vaginal vault, it can reduce the length of the vaginal vault. So that is why they are not usually offered for women, those who are sexually active. Now you have a 51-year-old who is undergoing abdominal hysterectomy for heavy menstrual bleeding due to multiple fibroids. For her, how would you prevent a vault prolapse? Options are Meckel's scaldoplasty. You can fix the uterosacral and cardinal ligaments to the vault. You can do sacrospinous fixation of the vault, or you can offer her a birch colposuspension. Just pause the video. Think what would be the best option. So here, remember, she is undergoing an abdominal hysterectomy. Meckel's is done whenever you are doing a vaginal hysterectomy. Sacrospinous fixation is for post-hysterectomy vault prolapse. or when you are doing a vaginal hysterectomy. Birch corpus suspension is done for other procedures. It is not something that is done to prevent post-hysterectomy vault prolapse. So here, fixation of uterosacral and cardinal ligaments to the vault, this is the procedure that is going to be most helpful for her. Okay. So this is the explanation that I just told you. Pause the video and read the explanation once again. Now you have a 70-year-old woman, she has cardiac disease, she has a mechanical valve in situ, she has hypertension, she has history of DVT in the past. Now she is presenting of a mass per vagina and she has been diagnosed as having a wall prolapse. No symptoms of urinary incontinence. She has undergone a total hysterectomy for heavy menstrual bleeding 4 years ago. What would be the best treatment option for her? Remember, she is a very high risk patient, cardiac disease, mechanical valve in situ, plus she has hypertension. Previously, she has had an episode of DVT. For her, offering some kind of major surgery is certainly not an option. So she's 70 years old, probably not sexually active. The best option for her is a colpoclysis, which can be done even under local anesthesia. And if she is not sexually active, that is the best option that can be offered to her. It is a comparatively non-invasive procedure as compared to the other procedures. Okay. Now let us see a few EMQs. So pause the video, read the options very carefully, read the questions, and then we will discuss what are the answers. So the first question here is, you have a 51-year-old woman who is presenting with mainly irritative symptoms, occasional stress incontinence, and the reason for her prolapse is a bothersome prolapse. She has undergone urodynamic study in which the flow rate is 50 ml per minute. She has urgency at 162 ml. She has strong urgency at 308 ml. There is no urodynamic stress incontinence, but there are detrusor contractions when she stands up with a full bladder. So, what is the best option that you can have here? Remember, the diagnosis here is no incontinence, but detrusor contractions. That means she has an overactive bladder. But she has come here with symptoms of prolapse. Okay. So the best option, remember that whenever you are having an overactive bladder or the detrusor is not very stable, you will not do any surgery unless the bladder becomes stable or you have treated the overactive bladder. Only after that, you will offer some kind of surgery. So the best option for her is defer surgery until the bladder becomes stable. Okay. Now, next is you have this 57-year-old woman. She presents with cystoscopy and urgency. Urodynamics were performed with a pessary in situ. There was no urodynamic stress incontinence, but detrusor overactivity was seen. So she already has a pessary in situ, detrusor overactivity is already there. What will you do for her? Okay. So for her, you have treated her prolapse symptoms, but she has now developed detrusor overactivity. So give her some drugs. So anticholinergics are the ones that are preferred or the other first line drugs. You will stabilize the bladder symptoms and then go ahead with any other surgery that would be required for the prolapse. Okay. Now, next you have this 74-year-old woman. She has history of vaginal hysterectomy and anterior repair, and she presents with urgency. She is on maximum dose of anticholinergics. Even with the maximum dose of anticholinergics, urodynamic studies show that she has severe detrusor overactivity but there is no urodynamic stress incontinence. What will you do for her now? She is on maximum dose of anticholinergics. Is there any other drug that she can be offered or any other procedure that could be done for her? Yes, you can offer her botulinum toxin. But before that, remember, you will refer her to the MDT or you will discuss at the MDT. Okay. So whenever you are contemplating any invasive procedure, always refer to the MDT, discuss at the MDT, and then go ahead and do the invasive procedure. Now, another set of EMQs in which you have to choose the most appropriate management for each scenario. Okay, these are the options. Read the options very carefully. You have the 64-year-old woman who is referred with symptoms of urgency. It was found that she is drinking too much of coffee, 6 cups of coffee a day. So she was advised to drink more fluids. So this corrected her symptoms. On local examination, it was found that she has severe atrophic vaginitis. What will you do for her if she has severe atrophic vaginitis? 64 years old, postmenopausal. The thing that you are going to offer her now is topical estrogen. Okay. So this will probably help to alleviate her symptoms. Next, you have this 59-year-old woman presented with bothersome urgency, incontinence, and she has a frequency of passing urine 6 times a day. The most troublesome symptom for her was nocturia. So she was given a trial of antimuscarinic medication. This controlled her daytime frequency and urgency, but nocturia has persisted. The best for nocturia is desmopressin. But remember here that you will have to offer her desmopressin only after a detailed consult, and you will rule out like hypertension or anything, and you will do an estimation of serum urea and electrolytes, and only then offer her desmopressin if there is no other contraindication. Okay. Lastly, you have this 42-year-old woman with overactive bladder, and she has control over her symptoms with anticholinergics. But she has very bad side effects. She has dry mouth, constipation, and now she doesn't want to take this drug because of the side effects. But her symptoms are well controlled with this drug. What can you do for her? For women who present like this, you can offer her oxybutylene patches. So dermal patches, they can be offered, and it is seen that with the dermal patches, like the side effects like dry mouth or constipation, whatever she has, those side effects are avoided. Okay. So these were the important points that you have to remember in urogynecology. Thank you for watching the video. I hope the video was helpful to you, and good luck for your exams. Thank you once again for watching. Bye-bye, take care, and do well in your exams.